Hi, this is Dr. Tom Murtaugh of the Christ Hospital in Cincinnati on behalf of the International Cardio-Oncology Society. Today we present highlights from a recent webinar on the diagnosis of AL amyloidosis. This can certainly be a diagnostic challenge, but Dr. Palladini presents several cases which illustrate an ideal approach to the patient with potential AL amyloidosis. ICOS is here to provide resources for clinicians and patients navigating the world of cardio-oncology. So check out ic-os.org for more information. And now we will introduce Dr. Palladini and hear his discussion.
So with that, I will hand over to Professor Palladini, who I will give a brief introduction. He is the acting director of the Amyloidosis Research and Treatment Center at the University Hospital in San Matteo in Pavia, Italy. He's the vice president and president-elect of the International Society of Amyloidosis. And as many of you on the call will know, his studies have led to the establishment of standard of care for the diagnosis, risk stratification, and treatment of patients with AL amyloidosis. And we are very fortunate to have him speak to us today. Professor Palladini?
Thank you very much for this nice introduction, and I am grateful for the opportunity of being here to discuss with you the pathway to diagnosis in AL amyloidosis. And I will try to do this with the help of a couple of clinical cases. The first one was a 74-year-old male who had no relevant medical history, who started developing exertional dyspnea that he had for 8 months. After that time, he was seen by a cardiologist as an outpatient, and an echo was performed, and the patient had an increased wall thickness. The cardiologist recommended a cardiac MRI that was done, and amyloidosis was suspected. And then after the MRI, a cardiac scintigraphy with bone tracers was recommended. That was done and showed a significant score 2 cardiac uptake. Based on these data, the patient was diagnosed with cardiac transthyretin amyloidosis and was sent to an authorized centers in our national health system for having access to tafamidis. However, the tests that you have to do to get tafamidis in Italy mandate a search for a monoclonal component. And an IgG lambda monoclonal component was actually detected. So the patient was referred to our center after a few months since the disease manifested for amyloid typing. We saw him in September 2019. The patient was heart failure class 3. Indeed, he had an IgG lambda, small monoclonal protein, with a low level, yet abnormal level of free light chain in the serum. The cardiac biomarkers were very high, both troponin and NT-proBNP. We had a tissue diagnosis on abdominal fat, and the amyloid deposits were identified by mass spectrometry as lambda. And the final diagnosis was cardiac AL, lambda AL amyloidosis. So the turning point in the diagnostic process was late in this patient. The cheaper and probably fastest test was actually done at the end of the diagnostic process, and what indicated the need of a biopsy-based approach was this small monoclonal component. And a few days after diagnosis, the patient unfortunately died before we could even start treatment. So we have many types of systemic amyloidosis. The most frequent you can encounter in your clinical practice are listed here. And coming to heart involvement, the two forms of amyloidosis that most common have cardiac involvement are AL, light chain amyloidosis, and transthyretin amyloidosis, both the wild type one, formerly known as senile, and the hereditary one. These forms have an overlapping clinical presentation, so it is very difficult to distinguish these forms between these forms clinically. Sometimes you may have involvement of the heart plus involvement of the kidney or the soft tissue such as macroglossia, and this is a strong indication of AL type amyloidosis. But most often you have no clinical hint to distinguish between these forms. And this is the relative incidence of cardiac amyloidosis type at our center in Pavia over the last 10 years. And you see that the number of AL amyloidosis remained pretty stable, but the number of ATTR wild type patients increased. And in the last 3 years, this is as frequent as AL at our center. So at our center, you cannot guess the amyloid type. You have a 50% chance of having AL or having ATTR, and you need specific testing. But the two diseases, even though they are similar in phenotype, are very different in the clinical course, because AL amyloidosis is a rapidly progressive disease, and patients with advanced disease actually have a median survival of only a few months, and most of them die within a few weeks, while even the patients with ATTR amyloidosis who are stage 3 have a much better survival compared to AL amyloidosis. So we are losing most of the patients with AL amyloidosis in the first few weeks, and we should consider AL amyloidosis as a medical emergency. So the first step when you suspect amyloidosis should be to rule out AL. Fortunately, we have a non-biopsy-based approach for diagnosing amyloidosis. This increased the diagnosis of non-AL, particularly ATTR amyloidosis, because you have cardiac uptake of bone tracers in ATTR amyloidosis, but and usually you don't have this uptake in AL amyloidosis. But there are cases, approximately 15% of patients with AL amyloidosis, and a strong cardiac uptake, and there are a few cases of ATTR variant without cardiac uptake. So in the presence of a monoclonal component, you need a tissue characterization. So the first step in the diagnostic process should be to look for a monoclonal component, which will be small in most instances because the clone is small. And so you will need to combine high sensitivity tests, immunofixation of serum and urine, and free light chain testing. When it comes to typing, the problem is that standard light microscopy, this is an endomyocardial biopsy, immunohistochemistry does not usually work because of non-specific staining for TTR usually. So this was a patient with cardiac AL that actually stained more strongly with anti-TTR antibodies. So what you can do is using custom-made antibodies or commercial antibodies, but using electron microscopy. But the gold standard is mass spectrometry that is not antibody dependent. With any of these technologies, however, you need to be expert, because each of these technologies has its pitfalls. So you need to send samples to an experienced center that has technology, but also expertise. And then there are patients that are discovered, that are diagnosed because of a peculiar reaction to standard cardiological treatment. Sometimes standard supportive cardiological treatment can actually do harm. And this was a subject. He was a 66-year-old who spontaneously requested a cardiologic evaluation for shortness of breath. He was seen by a cardiologist that found abolished vesicular murmur with pulmonary stasis, arrhythmia, And the only relevant thing that the patient had in the medical history was actually hypertension. So the local cardiologist performed an ECG and found atrial fibrillation conducted at a rate of greater than 120, but no echo was performed at that stage by the local cardiologist. And this was the prescription, particularly a beta blocker was prescribed. And subsequently, the dose of the beta blocker was increased by the general practitioner. And a few weeks later, the patient had worsening fatigue and a pre-syncope episode. So the patient was admitted to the emergency department. He had an acute heart failure with severe hypotension and a low cardiac output that was finally detected at an echo. And the echo showed a classical feature of amyloidosis and the diagnosis of cardiac AL type amyloidosis was finally made. So this patient clearly could not tolerate what initially looked as a standard treatment, and the diagnosis was missed for the lack of the first echocardiography.
What a great presentation of patient-centered clinical pearls and scientific information. We are grateful to Dr. Palladini for his ongoing work and today's discussion. Keep up with the world of cardio-oncology by joining ICOS and visiting our website. ICOS would like to thank you for listening to today's highlights and remind you to treat cancer, protect hearts.